Our first lecture on the series on cardiovascular drugs will be an overview of heart physiology, with a particular focus on its electrophysiology and how it is relevant to heart rhythm. By the end of the lecture, you should be able to describe cardiac electrophysiology and the cell types involved. You should be able to differentiate between nodal and myocardial cell action potentials. Finally, you should be able to explain how dysrhythmias arise and describe the different types there are. I'd like to firstly introduce the concept of a heartbeat, and to do that I'd like to show you what you might recognize as the standard pattern seen on an electrocardiogram or ECG. Shown on the slide is what is called the PQRST waves. These individual waves represent physiological events in the heartbeat, and as we will see shortly, arise due to changes in ion movements in specialized cells at particular locations in the heart. As you will see from the waveform, it begins with the P wave, which shows a slight rise on the line. This represents the activation of the atria. This means the atria can now contract and push all blood in them to the ventricles. This is then followed by the QRS wave, which represents the activation of the ventricles, and the ventricles can contract and push blood out to the lungs or to the rest of the body, depending on which side of the heart it is. Finally, there is what's called the T wave, which is a recovery wave in preparation for the heart to receive blood again. In a normal, healthy person, this rhythm should, in theory, be maintained throughout their lifetime until death. As we will see, though, there are situations that arise that can cause the heart to beat faster or slower or in an irregular fashion and give waveforms that are different as shown on the right of the slide. Our next slide shows the same wave pattern but highlights the structures where these waves originate and affect. The first thing to say about cardiac muscle cells is that they are electrically excitable. They respond to electrical stimulation by depolarization of their cell membranes. This means there is a potential difference or differences in ion concentrations or charge between the inside and the outside of the membrane. These are also interconnected cells in groups, so the electrical signals get passed on to their neighboring cells, allowing them to contract together as a unit. Cardiac muscle cells have spontaneous intrinsic rhythm generated by specialized pacemaker cells located in the sinoatrial and the atrioventricular nodes. This slide shows the two major cell types in the heart. First, we have pacemaker cells on the left, which can generate and conduct the electrical signals needed for muscular contraction. These cells have what is called automaticity, in that they can generate their own electrical signal once or without external nerves. The contractile cells in the diagram are muscle cells or cardiomyocytes. They are connected to neighboring cells by gap junctions, which allow electrical impulses to be propagated and transferred from one cell to the next, so that the chambers of the heart can contract as one. This involves the interaction of actin and myosin protein fibers in these cells. When we talk about cardiac cells being excitable, it's important to understand how this comes about. Electrical excitability is due to voltage-sensitive plasma membrane channels, selective for sodium, potassium, and calcium ions mostly. The diagram on the top right shows an example of one such channel, which can change its permeability depending on the potential difference or voltage across the membrane. Once open, it can allow the passage of a selective ion in or out of the cell, often dependent on a concentration gradient. Cardiac cells have pacemaker activity, meaning they set the rhythm. They have long action potentials and a refractory period or rest period, often related to the calcium currents. As shown in the diagram on the bottom right, heart cells have both intracellular calcium channels, these are called ryanodine receptors or IP3 activated channels, and voltage-gated calcium channels in the plasma membrane, being mostly of the L type. If levels stayed high, you would get a constant state of contraction rather than periodic. So removal of free cytosolic calcium is important and can occur by sodium and calcium exchangers, and also by the uptake of calcium by the sarcoplasmic reticulum and mitochondria. Normal sinus rhythm is generated by pacemaker impulses that arise in the sinoatrial node and are conducted in sequence through the atria, the AV node, the bundle of His, the Purkinje fibers, and finally to the ventricles. The diagram on the right shows the resting potential of a cardiac cell for each of the ions. This will depend on the concentration of specific ions inside compared to the outside. For example, a cell will have a negative potential for a positive ion if there are more positive ions outside the cell compared to inside, and will have a positive potential if there are more inside at rest compared to outside. This will change throughout the cardiac cycle, as we will see. The overall resting potential is a combination of all of these ions and is usually at minus 85 millivolts for a cardiac cell. This is mostly because sodium chloride and calcium ion concentrations are higher outside and potassium ion concentrations are higher inside. These potentials are maintained by channels, like the sodium-potassium ATPase. The resting membrane is more permeable to potassium ions. It is also worth mentioning at this stage that the force of contraction is directly related to calcium ions, the concentration of free calcium ions in the cytoplasm of the cell. This cytosolic calcium has two sources. Firstly, from the outside of the cell by opening calcium channels, and the second is from intracellular stores like the sarcoplasmic reticulum and the mitochondria, as is illustrated on the diagram in the right of the slide. Removal of free calcium needs to occur because if levels stayed high, there would be a constant state of contraction rather than periodic. This is regulated by sodium-calcium exchange and or the uptake of calcium by the sarcoplasmic reticulum and mitochondria. As mentioned already, pacemaker cells are responsible for initiating the electrical impulse by the movement of ions in and out of cells. For nodal cells, their typical action potential is shown on the slide, with the membrane potential on the y-axis and the time period on the x-axis. There are three main phases for nodal cells. These are called phase 4, phase 0, and phase 3 in that order. Phase 4 begins with sodium ions from the outside slowly entering through leaky channels in the SA nodal cells. This is followed by phase 0, which involves the opening of voltage-gated calcium channels and calcium entering the cell. Finally, voltage-gated potassium channels open in phase 3, and potassium leaves the cell and calcium channels close, and then the voltage-gated potassium channels close. The opening and closing of these channels generates the pattern shown on the graph. When sodium enters in phase 4, the cell becomes more positive. When calcium enters, it becomes even more positive. And when potassium leaves the cell, it starts to become negative. This pattern continues for every single heartbeat in a normal, healthy rhythm. This slide again shows the nodal action potential, pinpointing the exact timing of each channel, opening and closing on the graph. In some cases, the initial sodium currents shown in phase 4 are called funny currents and regulated by funny sodium channels. Please also note that there are different types of calcium channels at work, such as the L-type and T-type channels. We will talk about these later, and these are important in explaining some of the pharmacological actions of drugs we will discuss in later lectures. In contrast to the pacemaker cells, we also have action potentials in myocardial muscle cells. In this slide, we have a similar graph to the previous one, but a little more complex. The myocardial action potential is broken up into phase 4, phase 0, phase 1, phase 2, and phase 3 in that order. In phase 4, open potassium channels keep the membrane potential at around minus 90 millivolts. Sodium channels then open, and there is a large influx of sodium ions, making the cell more positive and increasing the membrane potential above zero. In phase 1, transient potassium channels open, and potassium is lost to the outside, making the cell slightly less positive. In phase 2, L-type calcium channels open, and there is an influx of calcium into the cell, causing the potential to be electrically balanced. In phase 3, calcium channels close, but potassium channels remain open, causing a decrease in membrane potential as more potassium moves out of the cell. Finally, in phase 4, the cycle begins again. This action potential gets passed from cell to cell in milliseconds, causing the opening and closing of ion channels. Electrical impulse originates in the SA node, as we have said, and this impulse travels quickly through the cells of the atria and then enters the AV node. Conduction through the atrioventricular node is slow, and this gives time for the atria to contract and move blood into the ventricles. The AV node sends its electrical signal over the bundle of His and into the Purkinje fibers, and finally into the cardiomyocytes of the ventricles. Ventricular contraction is fast. Shown in the diagram on the top right are the individual contributions of each of the channels and currents for each of the ions to the overall action potential that is generated. The diagram on the bottom right shows a typical cardiomyocyte with all of the channels involved and the movement of all ions at almost the same time. This occurs rapidly during the course of a single heartbeat. This slide summarizes simply what happens with ions at each phase and the net gain or loss of ions. Firstly, sodium comes into the cardiomyocytes, causing a fast upstroke. Then potassium is shunted out, calcium comes in, and potassium continues to move out. This gives a net gain of sodium and a loss of potassium in this cycle. While we have said that cardiac pacemaker cells have automaticity, this is generally not the only factor that dictates the rhythm. There are other inputs into the heart, such as nerves, as can be seen from the diagram on the top right. The heart is capable of beating on its own without innervation from the autonomic nervous system, but both sympathetic and parasympathetic fibers innervate the sinoatrial node and the atrioventricular node and can alter the rate of automaticity. Sympathetic stimulation releases noradrenaline, which binds to beta-1 adrenergic receptors in the nodal tissue. Activation of these beta-1 receptors in the SA node triggers an increase in pacemaker current or funny currents, which increases the rate of phase 4 depolarization and consequently to more frequent firing of the node. Stimulation of beta-1 receptors in the AV node increases calcium and potassium currents. This increases the conduction velocity and decreases the effective refractory period of the node. You can visualize the degree of this effect from the graph on the bottom right. If the parasympathetic or vagal activity is dominant, then the heartbeat or heart rate remains lower. If, however, there is significant sympathetic activity and that even becomes dominant, then the heart rate increases. The intrinsic rate without any input of sympathetic or parasympathetic activity is thought to be around 100 beats per minute. It is difficult to maintain a constant rhythm for an entire lifetime, and things can go wrong, either acutely or chronically. When something does go wrong with the heart rate, we can have chronic conditions developed that are called dysrhythmias. These can be subdivided according to their anatomical origin, such as supraventricular, meaning above the ventricles, i.e. the atria, and ventricular. The supraventricular dysrhythmias is where there's a problem with the SA node or with the atrial or atrioventricular junctions. Ventricular dysrhythmias has to do with a problem in the action potential in the ventricles that's being conducted. Sudden cardiac death, for example, is most commonly due to ventricular dysrhythmias. and often ventricular fibrillation or asystole is used to treated now with an automated or automatic implantable cardiac defibrillator or AICD, which you can often see around the university, for example. Dysrhythmias can also be categorized by their effect on rate, either increased, which is called tachycardia, or decreased, which is called bradycardia. The diagram on the top right shows what happens when you combine the individual action potentials we've just been talking about of all of the different regions, such as the nodal action potential, the myocardial action potential, and all of these regions together for what we know as the PQRS-T wave that we can often see on an ECG. We also see examples on this slide of ECG traces from a rhythm that is too slow on the bottom of the slide, which is bradycardia, and those that are too fast, which is tachycardia, on the bottom right. Dysrhythmias are disorders of either impulse formation, where there's abnormal automaticity, or they can be disorders of conduction, meaning the transmission or propagation of a signal. Contributing factors include things like ischemia, where there's pH or electrolyte abnormalities due to cell death, where there is excessive myocardial fiber stretching, where there is excess of sensitivity to things like autonomic nervous system transmitters like noradrenaline, or exposure to some toxins. Ectopic pacemaker or abnormal automaticity can occur because many cells are capable of spontaneous activity, but this is normally stopped by the dominance of the sinoatrial node pacemaker cells. Injury due to things like ischemia or hypoxia can lead to potassium imbalance, and this may cause these cells to become dominant in generating the cell rhythm. Most drug therapies block either sodium or calcium channels, and they reduce the ratio of sodium or calcium to potassium, and this ends up decreasing the slope of phase 4 in the action potential, or raises the threshold of discharge. This can decrease the frequency of discharge, and the effect is more pronounced in cells that have ectopic pacemaker. Triggered activity is when a normal action potential triggers an extra abnormal depolarization. There are two main types of these. First one is called early after depolarizations, or EAD. The second one is delayed after depolarizations, or DAD. These are depicted on the graphs on the top of this slide. EAD, or early after depolarizations, often occur during phase 2 or 3 and can lead to a ventricular arrhythmia called torsade de pointe, or twisting of the points. As you can see in the graph, it can lead to a repetitive after depolarization, meaning that the rhythm is changed from its normal pattern. The second type, the delayed after depolarization, occurs later in the rhythm during phase 4, again changing the rhythm from normal. Finally, impulse conduction disorders occur when there isn't so much a problem in generating the impulse, but in propagating or conducting it. This can be caused by a number of factors, such as AV block, re-entry, and or drug therapy. During AV block, the electrical signal travelling from the atria or from the upper chambers of the heart to ventricles, or the lower chambers of the heart, is impaired. This can be due to tissue or cell damage, usually caused by fibrosis or ischemic injury. This can cause bradycardia or slowing of heart rate. Re-entry disorders occur when an impulse is blocked in one direction and travels in a retrograde direction, re-entering the same conduction pathway for a second time, causing an extra or an irregular heartbeat. Examples of this include atrial flutter, and these often cause tachycardia or increased heart rate. Finally, with some medications or toxicants, they can interfere in the conduction pathway by interfering with ion channels, for example, by binding to them, and slow the conduction or increase the refractory period. We'll be coming across examples of these in the next lecture.